Good evening, I'm Dennis Ward, and this is Face to Face. Our guest this week is Dr. Barry Lavallee. He was recently named the Chief Executive Officer of a health entity formed by Manitoba, Kawetanhowie Okimakanak, which serves First Nations in northern Manitoba. The longtime Saulteaux Métis physician has focused his work on chronic diseases, transgenerational trauma, the impact of colonization on Indigenous communities, and international Indigenous health. Dr. Lavallee, thanks so much for being with us.
Yeah, I'm happy to be here. Thank you.
Let's start with the COVID-19 pandemic, and we've been seeing a major increase in the number of cases in Manitoba and everywhere, really. You're the CEO of a health organization that represents more than 30 Northern First Nations. What's the situation like in the North in terms of the number of active cases and what's taking place?
Well, unlike at the first instance when the pandemic was declared earlier this year, we're seeing numbers in a few communities. In reality, through a pandemic, this is not to be unexpected. So they're active at this point in time. We are certainly supporting chief and council and communities. We've developed a network of partnerships across jurisdictions to support communities. As well, First Nations have created a rapid response team, which is new, in order to augment any care and treatment and diagnoses through this pandemic.
It's just been announced that next week the North will be moving into the orange. What's that going to mean for communities as we move into a more restricted zone?
You know, putting a color code to the zone actually supports communities to be more careful. And the real trick about this, according to my public health colleagues, is trying to live with the pandemic. So it's a bit tricky. We're asking people to still try and continue in a safe way with your business, getting kids to school, going for your appointments. And if you have to travel into areas that are orange zone, it's to be extra cautious about following the recommendations by public health, like staying home if you're sick, wearing a mask, washing your hands frequently, avoiding crowds of any sort, really, that are not part of your bubble, and to try and stay home as much as possible.
What are the biggest challenges facing MKO communities during this pandemic? And as we move to orange, you know, gatherings are going to be limited to 5 people. Yes.
You know, before the call to move the North to orange, communities were already being as safe as an orange requires. So for some communities, this will be new. And you have to recognize in northern Manitoba, like in other areas of Canada, there are limited resources, even within our Northern Health Authority. The population is small, but for our population, about 70%, or 7 out of 10 people, if you come up north, are either First Nations or Métis. So predominantly, the healthcare system on either side of the jurisdiction is about health and healing for First Nations. So we work quite closely across that jurisdictional border. But what will end up happening is that people will be more cautious. People probably won't go to Thompson, some of the other towns, as often as they did before the numbers started rising.
Is there enough support being provided by the federal government and the province?
Well, you know, that's a really interesting question, because what we realized, certainly know about First Nations health and the factors that influence it, are the previously ingrained disparities, okay, and the limitations. So, and I'm talking about housing, I'm talking about access to technology in our communities. We're talking about education, employment, and all of those things, and including now an important topic to consider during the pandemic and afterwards is the impact of racism on First Nations people attempting to gain access to care. So all of those things have now been amplified. And it's a bit clearer for us as leaders to see that these previously ingrained limitations for First Nations people are playing a bit of a havoc in our communities.
You mentioned racism there. What has been the impact during this pandemic of that?
Well, you know, the concerning thing that we have, like a number of leaders, is that the limitations of people going into a center, you can only go by yourself, okay? Some clinics, you're sitting in the clinic 6 feet apart, but when you're being treated or evaluated, you're by yourself, and that's the rule during COVID to minimize spread into our hospitals. But what we recognize now is that limitation actually can increase the experience of racism directed at First Nations people. And so we're receiving multiple complaints to my office, stretched across Manitoba, with concerns about racist behavior by providers and by systems.
And we're certainly going to talk a bit more about that in a minute. But in the first wave, if we want to call it that, First Nations were very successful in keeping COVID-19 out of their communities. What's changed?
Well, what's changed is that the limitations imposed at the first instance that were pretty severe have now been lifted. So the virus, you have to imagine, I'm not a microbiologist or an expert in this particular area, the virus lives in humans. So it's human-to-human contact. And while we still say clean the surfaces, etc., really it's, when we look at the outbreaks, it's human-to-human contact. So we're trying to live a little bit more. We're trying to meet some family, have social distancing. But we recognize that the risk for the virus to get in is increased because we want to actually have a life. Mm-hmm. And so this part now, right now, is about us trying to live with the virus. And indeed, the virus will make its way into some communities, even with all the preventative things we do. The message really to our community people is to be as strict as possible with your family, with your own behavior. You know, we don't want gatherings greater than 5 or 10. We really want communities to think about doing celebrations another time. And so it's pretty tough. We've been talking with our chiefs and our leaders. It's very tough on the leadership right now to try and help community people sort out the degree to which they should be protecting themselves and their families.
Not having those gatherings and stuff is, of course, very difficult. And as we're shifting into what appears to be a long, cold winter, what should we keep in mind for people's mental health as this pandemic continues?
Yeah, again, thank you. That's very important. We are seeing increased activity and concern from our communities about people using substances to cope during this time. And again, do remember that the long history of trauma to First Nations people in Canada has exacerbated our need to try and deal with our traumas. And you have to imagine that this COVID and the threat in general exacerbates that. It makes it much more difficult. The advice that we're giving, we're using PSAs in Cree as well as Dene to try and get people to think differently about how they're living at this point in time. But we're also asking people to learn to be kind and to reach out to people in your life or in your community that you know might be alone to make sure that they're okay.
Dr. Lavallee, we had a guest on recently who's been looking into the impact of past pandemics on Native Americans. Are there lessons to be learned and put into practice?
Well, you know, again, that question arose during the first part of this pandemic. And we actually had some people alive today who do remember some of the pandemics that have occurred. And I'm talking not about smallpox, but about TB, about influenza, and those kinds of things. And you have to remember that from 1492 on, one of the three things that progressed in what appeared to be a genocidal wave across Turtle Island were infectious diseases. And there were communities in Canada who had smallpox, couldn't recognize it because the smallpox traveled through our ancient and ancestral communication roads that were crossed north to south, east to west. Remembering that our ancestors lived on this continent and communicated with each other. So that those viruses would go to a community two generations before they ever saw somebody white. Wow. So we know what pandemics are about and epidemics.
Dr. Lavallee, much more to talk about here, but we do just have to pause for a quick break, and then we'll continue the conversation here on Face to Face. Welcome back to Face to Face. Our guest this week is Dr. Barry Lavallee, and before the break we were talking about mental health and what some best practices maybe are during this pandemic. Dr. Lavallee, what help is there out there for those who are or may find it a difficult time this winter?
Sure. I'd really like to encourage people, should you start feeling down or if your concentration changes, any thoughts, negative thoughts, dark thoughts come to you, anything like that, please reach out to somebody, a friend that you trust. But do know there are hotlines that you can actually call that are federal as well as provincial and territorial. So keep those at hand for other members in your family and your friends. And do remember, if you also come from a smaller community, there are people working in your community who can actually attend to any emotional needs that you have. So please reach out if those emotions dominate you during this winter.
Helpful advice for sure. Dr. Lavallee, I'd like to talk to the broader healthcare sector. And last year there was a study that was released that found that health outcomes between First Nations and other Manitobans is widening. Some of the underlying factors mentioned were, ongoing trauma of colonization, racism, lack of clean drinking water, poor housing. How do we address these issues?
That the release of that information was very challenging for us to accept. What it actually demonstrated is that there's a widening gap rather than the gap closing in terms of health outcomes as well as other particular factors. And it reminds our leaders and the community people and the professionals who work from our communities that there's a lot more work to be done. But it also is a call to the governments and to the health organizations that they are not meeting the needs of First Nations people. And while that seems like a large sweeping accusation to colleagues and to the health system, that is the evidence that we're not addressing the needs of First Nations people seeking access to care and healing opportunities. Certainly the determinants of health are vitally important that they be corrected. But you also have to remember, and some other evidence that we have around chronic diseases is that in one part of the analysis, First Nations people were not gaining access to specialists compared to non-Indigenous participants. And while First Nations in that study done here in Manitoba were seeking care, something was going wrong because Indigenous people or First Nations people were being admitted for things that should have been taken care for in a clinic, but they weren't happening. There's not yet a full analysis on that study, but along with all of this information, we're not doing right by First Nations people. And I'm talking to the governments, the federal governments, the provincial governments, territorial, as well as the leaders in healthcare systems. That's exactly what that means, and we have a lot way to go.
Of course, we also know about the racism and how that plays into the healthcare sector. Is that something that you've been hearing about in your time, especially in your new job?
Yes, I've been hearing about this before I became CEO. So I've been working to address racism and examine it for about 10 to 12 years at this point in time. And we developed an anti-racist curriculum at the University of Manitoba here in the medical school, the first of its kind to address racism. Now, the issue of racism, as you see with the young woman who was killed by the two nurses in Joliette, Quebec, that this is an ongoing process that we actually can't even tackle in terms of determining how many people are affected by racism. I don't see any particular model that we can actually come up with a true number. Brian Sinclair is another case where he was killed by racism, actually. So, you know, with a recent emergency federal meeting on racism as one step to address racism federally, there's a lot of work that we have to do in the provinces and territories and closer to access healthcare systems.
Not one person lost their job when it came to the death of Brian Sinclair. The nurses in Quebec have lost their jobs, but you've called for criminal charges to be laid. Do you think there'll be any luck with those?
Well, you know, if I'm to bias anything right now, it's to call out to Joyce's family, and I will be an expert witness for you. I want that going out there in reviewing her case. Yes, Brian Sinclair did die of racism. We have all the evidence that we need. A group of my colleagues and I examined his particular case, and at every turn point, it was racism that led him to die alone in the emergency room at the Winnipeg Hospital.
And we hear of this game that nurses were playing out in BC. Dr. Lavallee, have you faced discrimination in your own practice or when you went through medical school?
Yes, well, commonly, and it still occurs today in 2020. I just sat on an appeal for one of our First Nations medical students to be able to support her. And what was clear to me was that the system still can't see how racism affects First Nations and other Indigenous peoples. And the real issue is that if you're white and in power, you could never see racism. So the logic then from the towers of power is that it doesn't exist. And what the federal government did recently was to give voice, multiple levels of voice to express how racism impacts us, not only personally, professionally, but also our patients. Okay, it exists, all right? So there's no need for us to actually try and convince people that it exists. What we need are actions. And in the case of Joyce, I asked for prosecution, that those two nurses participated in the killing of Joyce. And I also advised that there would be no need to do an autopsy, because the autopsy will never show how racism looks and impacts the body unless it's an extreme physical injury.
Dr. Lavallee, we do have to step aside for another quick break, but we will be continuing the conversation here on Face to Face with Dr. Barry Lavallee. Stay with us. Welcome back to Face to Face. Our guest this week is Dr. Barry Lavallee. And before the break, we were discussing racism within the healthcare sector. But Dr. Lavallee, in 2019, you resigned from the University of Manitoba, the second Indigenous administrator at the time to do so. What was going on?
Well, you know, what prompted that move was the frustration of not being supported to address the racism that the Indigenous medical students and other students were having to contend with, while at the same time trying to keep high marks to be successful in their very difficult programs. And it fell on deaf ears. And I made a comment in the Free Press or one of the papers one time that racism comes in nice, white, smiling faces. And that level of frustration just got to me. And I decided to leave and seek work somewhere else. So I no longer teach for the University of Manitoba. I left in protest that there was nobody or no system or nothing really seriously wanting to address the normalized racism against Indigenous people in that higher institution of learning.
Of course, we know this isn't a University of Manitoba problem. There have been high-profile resignations at post-secondary institutions in Ontario and Alberta. How bad is the discrimination in academia?
The discrimination is as bad as you see it anywhere else. I want the people listening to me that having a degree or a diploma or a doctor in front of your name does not mean you can't be racist. The assumption is that people who speak English or French well and study things aren't racist. This is completely not true. Even with our researchers that we support, a group of Indigenous scholars and community people have developed a system to help them understand their need to change, to be self-reflective, considerate of the words that they choose to use, and examine them as part of a process to change the hard drive that Canada creates in settlers to our lands.
Dr. Lavallee, we only got a little over 1 minute left here or so, but let's try to leave on a more upbeat note. And you're part of a team that will be receiving a Univant Award of Excellence, a prestigious award. Can you tell us about the work done to receive this recognition?
Sure, thank you. What's important, not about the award, but about the work that we're accomplishing. We're really trying to reduce the need for dialysis in First Nations communities, especially for our northern communities. Really, in some places, when you look, 1 in 3 people are First Nations receiving dialysis. So we started that question, that query, why is this so, way back? And we worked with some of our nephrologists or kidney specialist colleagues, and we developed a screening project using point-of-care testing to go in communities. And we successfully screened 2 tribal council areas in Manitoba and discovered that there's about a 1 in 3 risk for kidney disease. But really what we accomplished was that First Nations people needing to see a kidney doctor, we facilitated that far better than any primary care system that I know of. And so that work is being recognized, that we use technology, we engage respectfully with community people, and we try go way upstream and prevent the need for any replacement therapies like dialysis.
Well, great work, Dr. Lavallee, and congrats to you and the team. And we thank you. We're all out of time, but thanks for doing the show. And
thank you so much.
Good luck with the new gig and navigating this pandemic.
Okay.
Thanks for being with us.
Okay, bye-bye.
And that is all the time we have for this week. You can catch up on any episodes you may have missed by visiting our website, aptnnews.ca, and all of our shows are available as podcasts. You can find those at aptnnews.ca/face-to-face. I'm Dennis Ward. Thanks for tuning in. We'll see you next week.